Preeclampsia. In this video, I will discuss the signs and symptoms, risk factors, complications, and racial disparities associated with preeclampsia. I hope this video provides education and awareness to the seriousness of the disease. Preeclampsia is defined as the development of new onset hypertension and proteinuria after 20 weeks gestation. Hypertension in pregnancy affects 5 to 8% of pregnancies. In 1 year, 76,000 mothers and 500,000 babies were affected by preeclampsia. Risk factors include greater than 35 years old, a prima gravida, African American women, history of preeclampsia, a multiparous pregnancy, chronic conditions such as hypertension, diabetes, chronic kidney disease, obesity, or connective tissue disorder. African American women are 3 times more likely to develop preeclampsia. This is caused by the rise in obesity and socioeconomic status. Prenatal care and financial status have also been known to affect preeclampsia. Studies have shown that lower socioeconomic status, cultural and educational barriers, and lack of insurance and prenatal care lead to disparities in African American women. Because of socioeconomic status, many African Americans do not have health insurance, transportation, or education about health care, leading to limited prenatal care and lack of health care resources. Preeclampsia is diagnosed late in these cases, leading to delayed treatment and occasionally negative and detrimental outcomes. Symptoms of preeclampsia include proteinuria, hypertension, headache, shortness of breath, sudden weight gain, nausea or vomiting, hyperreflexia, edema, change in vision, and right upper quadrant pain. To diagnose preeclampsia, there is a presence of proteinuria in the urine, a low platelet count, impaired liver function, and high blood pressure. According to the new Task Force report on hypertension in pregnancy, ACOG no longer requires the presence of proteinuria to diagnose preeclampsia. The president of ACOG, Dr. James Martin, said, "Preeclampsia affects so many women and has so many potentially dangerous outcomes, including preterm delivery, severe hypertension, stroke, and seizures, even death of the mother in the worst-case scenario. Detecting it early and treating it well is a major global health need." Dr. Martin also states the problem is that many women don't have enough proteinuria to meet the former criteria, so their treatment is delayed. Treatment includes corticosteroids to increase low platelets, blood pressure medication to lower blood pressure, magnesium sulfate to prevent seizures, but the most effective method is the delivery of the infant. When delivery isn't an option due to a non-viable fetus or preeclampsia is considered mild, providers will order betamethasone for fetal lung development, encourage bed rest, elevation of feet, consume less salt, decrease stress, and drink at least 8 glasses of water a day. If preeclampsia is not treated quickly, it can lead to maternal complications, including liver or renal failure, future cardiovascular issues, eclampsia, HELLP syndrome, and death. Infant complications include low birth weight, preterm delivery, and sometimes death of the infant. At 32 weeks, I was diagnosed with preeclampsia. I experienced the classic symptoms of high blood pressure, sudden weight gain, headache, and edema, along with proteinuria and elevated liver enzymes. I was admitted to the hospital at this time and given betamethasone shots to help mature my baby's lungs. 24 hours after my second betamethasone shot, I was induced, and my son was born at 33 weeks. He weighed 4 pounds and was 16 inches long. He spent 3 weeks in the NICU growing and learning to eat. This is Easton. He turned 5 years old last week, and thanks to medical advances and providers who knew what to look for, my son and I both lived, and neither of us suffered any of the complications associated with preeclampsia.